Okay, class, we're going to continue on to chapter 2. Again, most of this should be a review, but we're going to talk about motor learning and recovery of function. Last time in chapter 1, we talked about motor control. So motor control is you already have the ability to do something. It's how well do you do it. Motor learning is the ability to understanding the acquisition and modification of skilled action. Can you acquire a new motor learning pattern after a stroke, after CVA? Okay, so that's the difference between motor control and motor learning. Okay, just to interact. While motor control focuses on understanding the control of movement already acquired, motor learning, which is what we'll discuss in this chapter, focuses on the understanding and the acquisition and or modification of a skilled action. So what contributes to recovery of motor function and what factors constrain it? Well, how much of that recovery is initial recovery is due to spontaneous recovery? First stage, how much do they occur hours afterwards? Second stage, 1 to 6 weeks is where most recovery takes place after, especially after a stroke. After 6 weeks, the recovery is much slower. So the first 6 weeks of recovery is the best. The third stage is the chronic repair. That can be months and years. And by the time we see a patient, usually they're in the third stage of recovery. And that's why we can't say in 6 months, I'll be able to make you walk. It could take years. And there's a lot of other factors that can control how long it takes to recover. So how much recovery is attributed to therapeutic interventions? Like how much can we actually play a role? If somebody's had a stroke for 14 years and they say, oh, I'm going to come into rehab, how much real change can we make? Unfortunately, probably slim to none. But if somebody comes in the first 6 weeks after a CVA or an accident, then we can make huge amounts of recovery. So the early on prevention after a CVA, so if you've had a family member or you know someone or a patient, you want to try to get as much motor learning as possible in the first 6 weeks after a cerebrovascular accident. How much will continue to improve? So how much will we continue to improve after we're done with therapy? So motor learning is the study of and understanding of acquisition and or modification of skilled action. The recovery of function, reacquisition of movement skills lost through injury. So before the patient was able to go up and down stairs, bathe themselves, put on their clothes, take off their clothes, comb their hair. Now, can we retrain them? Can they reacquire those movements lost after the injury? How can I best structure therapy to ensure learning? And what is the best way to promote neuroplasticity and reacquisition of movement skills? So what are some techniques that we can use to promote this neuroplasticity and again, even though this is actually more neurological, maybe there's certain things that you can pick up from orthopedic side that you can use with your orthopedic patients as well. Understanding the neural system, the neural connection, pain science, and you'll be able to put that together. So early definitions of motor control were process of acquiring capability for skilled action, results from experience or practice, cannot be measured directly, inferred from behavior, and produces relatively permanent changes in behavior. So in this chapter, we'll also discuss the definition of motor learning has its broadening the definition, right? So it's a complex of perception, cognition, action, processes. So motor learning involves more than just motor process. It involves learning new strategies for sensing as well as moving. Thus, motor learning, just like motor control, emerges from a combination of the perception, the cognitive, and the action processes. So you can see that motor control and motor learning are very, very similar. But remember, motor control is the ability to change what we already know, and motor learning is learning something new. Task solutions, new strategies for perceiving and acting. So before, the old school theories were that task solution emerges from an interaction of individual themselves. But now they've found that task solutions usually emerges from the interaction of the task, the environment, and the individual. So that's why it's broadening the definition. And that's true. Remember, for motor control, in order for the individual to complete the task, we have to look at the environment. So same thing with motor learning. Do I learn best in a crowded place? Do I learn best in an isolated place? Do I learn best with family around? Do I learn best with no family around? So those are all things. What's the task at hand? Do I even want to do this task? So if the therapist is going to say, okay, put this cup over there on the cupboard, and the patient's like, well, hell, I never do that. Well, what's the motivation for them to even try that if there's no reason for them to ever do that task once they leave rehab, right? So you have to be able to ask the patient, why are you doing something when what are you going to be doing in the house? So to make it fun. Now, relating performance and learning. Learning is we want a relatively permanent change, nothing temporary. So yeah, it's great that they can do it in rehab, but we want to make a permanent change. Patient can do the task at the end of therapy, but if they forget it by the next session, then that's not really motor learning. Performance, temporary change in motor behavior seen during practice sessions, but recovery of function involves reacquisition of complex tasks. We need to make a permanent change for it to be true motor learning. So a good clinical example of this is, and we'll talk about case studies, but if we look at, let's say, Janice, the patient with an acute stroke, and you bring her into therapy, and let's say she's always on the uninvolved leg. So let's say she had a right CVA that will affect her left side. So because she doesn't want to put all her weight on the left side, she's going to kind of have a bias towards her right side. But in therapy, you're working, and then finally by the end of the session, she's evenly distributing her weight on both feet, which is fantastic. But then when she comes back 2 days later, she's back on her right side again. So that tells you that no motor learning occurred. Okay, that's just a temporary thing. We need to, when she's able to come into therapy and she's able to distribute the weight evenly without us giving tactile cues, verbal cues, or telling her what to do, then we can say that yes, motor learning has occurred. And that takes time. That takes effort. That takes patience. Okay. Now, in order for us to understand how patients recover with long-term memory, well, we have to understand the different aspects of long-term memory. So there's two types. There's non-declarative, implicit, and there's declarative, explicit. So declarative, explicit are just facts and events. Can you remember facts and events? Okay, so but what we're going to start off with is non-declarative, which are implicit forms of learning, and we'll break that down. Okay, so this is a part of long-term memory. This is part of non-declarative, okay, and these are implicit forms of learning. So what that means is one aspect of non-declarative or implicit forms of learning is non-associative learning. So let's say you have an animal, let's say a chimp or a rat or a rabbit, and animals are given a single stimulus repeatedly. Push the button, get a cookie. Push the button, get a cookie. Push the button, get a cookie. Pull the lever and you get shocked. Pull the lever and you get shocked. So, well, obviously you need to only pull the lever one time and you decide, okay, I'm going to push the button and get the cookie, right? But there really isn't motor learning that's going to occur right here, right? It's just non-associative learning. It's just basically pushing the button, right? You learn that if you pull it, but you know, sometimes if you see another lever, the animal is going to pull it again. So there's really no carryover to that. So when you're given a single stimulus, non-associative learning, it really isn't. So if you look from a rehab standpoint, it doesn't make sense for the patient to do the same thing over and over again. Okay, there's not going to be any motor learning that occurs. Okay, habituation is decrease in responsiveness as a result of repeated exposure to non-painful stimulus used to treat dizziness or vertigo. So when you have BPPV, Those are when the crystals in your ear get a little whacked. If you've had a car accident where you hit the side of your head, or maybe riding a roller coaster, you get those little crystals messed up. I rode that Harry Potter ride at Universal Studios. Man, I'll never ride that damn thing again. I was dizzy for a while. My kids loved it, but I hate that thing. Anyways, BPPV technique is basically what you're gonna get them a little dizzy and you're gonna stop. You're gonna get them a little dizzy, and then so your body gets used to that, and then hopefully it can heal that way. Now, sensitization is increased responsiveness following threatening or noxious stimuli, painful stimuli followed by a light touch. You may still overreact to the light touch, so the therapist educates awareness of environment to decrease fall risk. So we know that patients have fallen maybe on slippery floors or wet floors, and they're aware of that because they fell and broke their hip or whatever the case may be. So every time that they walk on something slippery, they're going to have an increased response. They're like, oh man, I better be careful, okay, because they know that they fell last time. So they're sensitized to that. Now, there's also associative learning, so predicts relationships through classical or operant conditioning. If a patient has a stroke on the right, he will put less weight on the left due to fear of falling. So that's associative learning. They know that if they put weight on that side, they're going to fall. So guess what? They're going to take the weight off of that. So that's why anybody that has a stroke, let's say they have a right CVA, they're going to put more weight on that right side, because remember, strokes affect the opposite side, so they're going to trust the right side, they're not going to trust that left side. The classic conditioning, learning to pair two stimuli. Remember Pavlov? Now, people always say Pavlov's press. Those that are personal trainers, you know what I'm talking about. People say, oh, let's do the Pavlov's press, but it's not really Pavlov, it's Palov. Palov is the Russian weightlifter. Pavlov was the scientist that if you ring a bell and you get food, okay, that's classic conditioning. Therapy, you give verbal cues to perform the task. So that's classic conditioning. Okay. Operant, instrumental conditioning, trial and error. You push a lever, you get food. Push a lever, you get electrocuted. Then you don't push the lever, right? Well, that's pretty easy. Okay, so that's operant. And then procedural learning, learning tasks automatically without attention or conscious thought. Practice tasks repeatedly in varying contexts and environments. So, well, if we're going to teach a patient to walk, we're going to teach them to walk on carpet. We're going to teach them to walk on tile. We're going to teach them how to walk on different surfaces. Unfortunately, in rehab, we can't predict every kind of environment that they're going to be in. So we do the best that we can. So you can see from a rehab standpoint, well, what are some things that we can use? What kind of forms of training we can use and develop long-term memory? So basically, we're just learning the basics, right? You probably already do a lot of this stuff, but this is the theory behind it, why we're doing stuff. And then we can look at research and say what works and what doesn't work. So for some patients, it was just trial and error. Like, oh, I tried it and it didn't work, or I tried it and it worked. But now we can understand, if we understand the theory behind it, maybe we go straight to what works versus just being around the bush and wasting everyone's time. All right, so again, basic forms of long-term memory. You have non-declarative or implicit learning, more reflexive, automatic, or habitual in character, frequent repetition for its formation. Again, so more reflexive, automatic, habitual, frequent repetition for its formation. That's non-declarative. Declarative learning, so this is the other type of long-term memory, that knowledge that can be consciously recalled, processes such as awareness, attention, and reflection, ability to remember factual knowledge, and the types of processing, encoding, consolidation, storage, and retrieval. So you tell the patient, button the first button, then the next one, move your nose over your toes, right? So you're telling them step by step. So, okay, this is what we're going to do. This is what we're going to do. What we're going to do. Okay, so tell the patient, button the first button, then the next one. So you're telling them a sequence. Move your nose over your toes. So these are sequences, whereas non-declarative is just automatic, habitual. Do one thing, bam, 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 bam. Okay. Now, declarative versus non-declarative. So depends on location of lesion. What would you use on patients? Well, it depends, right? Where did they have the injury on the brain? Okay. What type of CNS pathology? Was it a stroke? Is it CP? Did they have polio? Declarative requires verbal expression. So difficult with cognitive or language deficits. So if the patient can't speak and have language deficits, then declarative is going to be difficult. So that kind of learning is going to be difficult. We're going to have to use non-declarative first. If they had a stroke near the right hippocampus, they're going to have issues with spatial representation. If they had an injury to the left hippocampus, they're going to have issues with memories of words and objects. So there's not one cookie cutter recipe, and if that's the take-home message of the whole semester is I can't tell you to do one thing for every single patient, whether it's a stroke, CP, polio. We have to know where's the injury, what type of injury is it, what's the environment, what's the task that are performed, and then we can make a personalized rehab program for that. But we have to learn all the normals first. But remember, take that into consideration, all these considerations before you just blindly give them exercises to do. And again, that goes for the outpatient rehab as well. Just because they come in with the ACL doesn't mean you do the same exercises for that ACL. Depends on their age, depends on the injury. Are they going to go return to volleyball? Are they going to return to soccer? Are they going to return to basketball? That will gauge what kind of exercises that we do later on. Initially, they might be the same. But later on, we have to make them special. It's the same thing with this. Initially, we can do the same exercises for a stroke, CP, polio, but then we might have to change it up. So long-term memory is in association courses, so damage to hippocampus would not affect early memories. Overall rehab should be goal-oriented. Here's the key. Research has shown best results when the patient is highly motivated, attending fully to the task, and can relate to the task. So that's what I want you to do. So again, going back to if a patient wants to go return to walking and all you do is put him on the bike, well, he's not going to be highly motivated because he's like, I'm never going to ride a bike. But you can initially do it, but then explain to them that, hey, we're going to eventually start to walk. So you have to associate that. Now, what are the theories of motor learning? Remember, there are theories of motor control. Well, there has to be theories of motor learning. And remember, these are just abstract ideas that people have put together and say, okay, what are some of the ones that we're going to use here? And they all have clinical limitations, implications, and limitations. So in the Schmidt schema theory, 1970s, Richard Schmidt, the schema theory, open loop control processes and generalized motor program concept. Schema, abstract representation stored in memory following multiple presentations. You're thinking, what the hell does that mean? So let me give you an example of the schema theory, right? So let's say you have, after seeing many different types of dogs, let's say you see a whole bunch of types of dogs, right? You understand that once you've seen that, you understand what are the rules, the general rules for what a dog looks like, right? In our brain, we know that they can have hair, no, they've got a tail, they pant, they make the rough sound, so that whenever we see a new dog, no matter if it's a different color, if it's a different shape, different size, we're still able to identify that as a dog, even though it has different characteristics. Does that make sense? So it's an abstract representation of what a dog is. So taking that into rehab, if we can give this abstract representation of what walking is, if we can give an abstract representation of what a squat is, then it doesn't matter if we were to do a squat on a hard surface, a soft surface, with weight, without weight, single leg, blindfolded, you still understand the concept of what a squat is. Right, so that's the whole schema theory, and it's a good theory, and we use that all the time. We just don't realize that that's what we're using. Now, storage and short-term memory, initial movement conditions, parameters used in generalized motor program, outcome movement in terms of knowledge of results, sensory consequences of movement. Basically, the individual learns a generalized set of rules that can be applied to a variety of contexts. For example, even if you see a whole bunch of different dogs and see the different characteristics, nose, tail, body, you still associate as a dog. That was the example that I gave you. Now, from a clinical standpoint, learning will occur if tasks practice under many different conditions. So what we want to do is, if we do the same behavior over and over and over again, you're not going to learn it. So reaching for a glass of milk with her affected limb under many conditions, name a few. So let's say we are trying to teach this patient how to reach in the cupboard, right? So we can't use the same glass over and over again or the same height. So we want them to try different heights. We want a big glass, a full glass, an empty glass, a slippery glass, a wet glass. So we want to change that around. Even though the task itself is just reaching for the glass, we need to change those parameters, and that's how motor learning will occur. Does that make sense? So limitations, results of research mix, better improvement in kids, 7 to 9-year-old versus adults. So of course, so limitations, they didn't have too many results with adults, but they found fantastic results with kids. So when you're working with kids, mixing it up and having them try different tasks is a fantastic way for them to learn and motor learning. And it lacks specificity. Overall, practice produced a cumulative continuous change in behavior due to a gradual buildup of strength of motor programs. So variety is the spice to life, or isn't that what they say? So keeping it variable is actually a good way for motor learning to occur. Now, the other theory, which is the ecological theory, Newell. Remember, there's an ecological theory for motor control. Well, there's also an ecological theory for motor learning. Motor learning increases coordination between perception and action consistent with task and environmental constraints. Emphasizes dynamic exploratory activity of perceptual motor workspace to create optimal strategies for performing a task. Now again, what does that mean? Right, I always talk about this, but what does it mean? So from the ecological theory, difference from the schema theory is in the schema theory we gave a bunch of rules, a set of rules, and they're able to accomplish the task. In the ecological theory, Newell emphasizes that patients will learn by exploration. So you tell them to do the task, and then basically by exploring and finding different things, they'll be able to adapt to that. So by reaching, if they're able to explore themselves and they're able to say, okay, this glass is heavy, well, I'm going to need a little bit more force to grab it. So exploration is more emphasized in the ecological theory versus whereas in the schema theory is you have these set of rules and you must follow these set of rules. Right? So there's more exploratory involved here. So clinical implications, patient must learn to distinguish perceptual cues important to organizing action. Patient must learn the perceptual cues such as the size of the glass, how slippery the surface is, how full the glass is on their own. Therefore, not only should be able to reach for the glass, but adapt to the perceptual cues. For example, if the glass is full, she will need more force. If unable to adapt, she will drop it. So from a schema theory, you're just one theory. In this ecological theory, you're able to adapt by manipulating the environment and exploring new things. The limitations, new theory yet to be applied to specific examples of motor skill acquisition in any systemic way. So this theory is like, well, how do you put them into all these situations where they can practice that? It's nearly impossible, right? There's no way that we can reproduce everything. So there's some clinical limitations. Again, these are just theories. These are the scientists that say, okay, let me try to explain how we learn. They're abstract ideas. There's just one way of doing things. And again, in rehab, we do a lot of this stuff. It's just we can't name the theory that we're using behind it. So these scientists are trying to explain why we do certain things. And there is some research backed on some things later on that we'll learn, and those are the theories that we want to focus on.